Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss-Studientelegramms, Marcus at Home welcomes Dr. Helen Lachmann in London, UK, with whom we would like to discuss pathophysiology, diagnosis, and treatment of amyloidosis. Helen, it's a pleasure for us to have you tonight. Thanks for taking the time.
Thank you for asking me.
Dr. Helen Lachmann is Professor of Medicine at the National Amyloidosis Centre at the UCL in London, UK, which is the biggest center in the world with a specialist interest in treating systemic autoinflammatory diseases. Beyond her clinical work, she has conducted seminal studies in the field of amyloidosis, and in the last 2 decades, she's published 200 papers on amyloidosis. So it's really a privilege for us to have you. My co-moderators are Marlies Antlanger from Linz, Austria, Andreas Kronbichler from Innsbruck, Austria. My name is Gunnar Heine from Frankfurt, Germany. So I start with the simple questions, and then Marlies and Andreas will take the more difficult ones. As first question, I would be eager to learn your preferred definition of amyloidosis. So for all our colleagues who are not really in this particular field of medicine, who do general medicine or who are medical students, how would you define amyloidosis to them?
So amyloidosis is a disease of protein folding in which normal proteins, which should be circulating in the blood, refold into an abnormal conformation in which they are deposited as fibrils. And these are defined histologically, largely by their staining with Congo red dye, where they have characteristic birefringent staining. You can also define them with a signature on mass spectroscopy, where you can see that they bind serum amyloid P, apolipoproteins, and the fibril proteins. And you can also define them immunohistochemically and by looking at their ultrastructure. But it's a structurally defined disease in which proteins are in an abnormal conformation in which they auto-aggregate to form fibrils, which accumulate in a pathogenic fashion, thereby disrupt organ function and structure, causing progressive and in the systemic forms almost universally fatal disease if untreated.
So apparently the prevalence of amyloidosis has been underestimated until recently. Would you share a reasonable estimate of its general prevalence with us?
So I think it probably is the cause of death in at least between 1 in 1,500 and 1 in 1,000 individuals. It is underestimated. Amyloidosis in general gets commoner as you get older. Under the right conditions, if you push it hard enough, almost any protein can be forced to form amyloid. In physiological conditions in man, more than 30 different proteins will form amyloid. In clinical practice, looking at systemic amyloidosis, we're really interested in about 13 or 14. But we know, particularly in the very aged individuals, that a large number of normal proteins, but particularly transthyretin, which is the carrier protein for vitamin A, and which is also a carrier protein for thyroxine, and which is normally synthesized by the liver, will eventually form amyloid, as in all of us, probably as we get older. And this has been increasingly recognized, largely due to advances in cardiac diagnosis, particularly the widespread use of cardiac MRI, but also some nuclear medicine scans, DPD and PYP scintigraphy, that this is now getting really, really commonly recognized as a form of late onset heart failure, particularly in men. So as we live longer and our populations age, eventually I think all of us are going to run into problems with our aged proteins, and our aged proteins will show a tendency to auto-aggregate and to form amyloid. We're not going to live to be 1,000.
And you have a particular schema in UK because really patients are referred to your center from all of England, I guess. So how many patients do you see each year in your center who are surely kind of pre-selected? And then how many of these patients can you finally confirm and give a definite diagnosis of amyloidosis?
So you're quite right. Our colleagues do the really hard work, which is recognizing who's got amyloid or who there's a high suspicion of amyloid in. And we have the, in some senses, much easier role of having the machines, which and all the expertise and technology, which means that we can then try and either confirm or refute the diagnosis of amyloid and type it. But the hard work in recognizing who's at high risk has been done elsewhere. We see about between 5,500 and 6,000 new referrals a year, patients a year, of whom about 1,500 are new referrals, with a view to either excluding amyloidosis or typing it. And our failure rate in terms of not being able to definitively type the amyloid is less than 1% a year. So we can usually make some form, type the amyloid in 99% of the patients who are seen. And we do that by a combination of techniques. So the patients physically come down to us, and so we see them and take a history. We do a number of imaging techniques. We have a dedicated cardiac MRI center, echocardiogram, and we have nuclear medicine scans. We do DPD scintigraphy, which is a very sensitive means of looking for particular form of amyloid, TTR amyloid in the heart. We do SAP scintigraphy, which is very good at picking up systemic amyloid in the larger organs in the body. So it's extremely sensitive for looking for amyloid in the liver, spleen, kidneys, or adrenal glands or bone. And then we have our own dedicated laboratory, so we can review the histology, perform immunohistochemistry, perform mass spectroscopy, which is a much more sensitive technique of looking for amyloid in histological tissue, and we do our own genetic testing. Putting all of them together, and therefore being able to look at all the different facets of disease, gives us a very strong and powerful diagnostic set of tools to combine.
And each and every patient who comes to your center really gets all these diagnostic tools and diagnostic
so they get what they need. So some types of amyloid are easier to diagnose than others. My particular interest has been in AA-amyloidosis, which is a complication of chronic inflammation. And that is in many senses the easiest of the types of amyloid to diagnose. There's often a characteristic history of decades of a chronic inflammatory disease. This almost always presents with proteinuria kidney renal dysfunction. This means they tend to have had a kidney biopsy, which is beautiful tissue for immunohistochemistry. And the immunohistochemistry for this particular type of amyloid is exceptionally clean. So in AA amyloidosis, we usually have the nicest tissue to work with. The monoclonal antibodies are extremely good, and we probably don't need to move on to other techniques. AL-amyloidosis, where this is a complication of plasma cell dyscrasias, and you're looking at bone marrow disorders which are producing variant light chains almost always. The variant light chains are individual to each patient, and that means that immunohistochemistry is much more difficult because you may not recognize the epitopes expressed by that particular clonal light chain. And diagnosis by immunohistochemistry is therefore much more difficult, and we therefore rely much more on proteomics, and you may need to actively exclude disease by genetic testing. And in patients with hereditary amyloidosis, we obviously need to do genetic testing. Often you can spot the gene, and then you may end up doing a single gene analysis. If we're less clear, you may end up doing a panel analysis, and we're then looking at all the genes that are known to be associated with hereditary amyloidosis.
So my last introductory question before switching the mic and to Andreas would be the distribution of these different subclasses of amyloidosis. So we found a Lancet reference paper some years ago, which stated that around about 2/3 of amyloidosis are AL-amyloidosis, and then the second subclass would be AA at around about 12%. But apparently things changed in the last years. So what are your really experiences and your data in London?
So that's true. It's really changed over time. So AL-amyloidosis still remains the commonest type that we see, and that for us is about between 50 and 58% of new referrals. AA-amyloidosis, complicating chronic inflammation, historically was the second commonest type, but that has got much rarer, and that's for a number of reasons. For reasons that we've never understood, AA-amyloidosis was always rare in North America, and the explanation for that has never been clear, and the populations who had a very high risk of AA-amyloidosis because they had a disease called familial Mediterranean fever, which is complicated by a very high risk of AA amyloidosis when untreated. A large number of them ended up in the States because of the Armenian diaspora, and they took with them familial Mediterranean fever, But they didn't take with them the risk of AA-amyloidosis, which for those who remained in the Eastern Mediterranean is about 60% if you have untreated FMF, and which when they came to Northern Europe, if not as high as 60%, certainly exceeded 50%. And we never understood why they didn't get AA-amyloidosis in the States. In Northern Europe, including in our practice, AA-amyloidosis across the almost 25 years now that I've been doing it has gone from being about 10% of our new referrals to being less than 2% of our new referrals. And this is largely due to improvements in care in the last 25 years in rheumatology. And this is the advent of biologics and the fact that rheumatoid arthritis is now a disease in which you will be pretty confident of expecting a good long-term outcome. And the anti-TNF agents and anti-IL-6 agents have meant that we really don't see devastating uncontrolled rheumatoid arthritis anymore. A generation before me, we saw AA-amyloidosis complicating untreated and untreatable infection, whether that was osteomyelitis, leprosy, or TB, and then that disappeared. So there's been this miraculous time of essentially seeing a life-threatening disease almost completely disappear because the underlying infections and chronic inflammation that underlie it have become treatable. And what we hope we'll see that in the other diseases. What has become much more common, and this is ascertainment, this is because diagnosis has got much better, is wild type transthyretin amyloidosis, which is this disease of the elderly, particularly of men. We see about 94% men, and this is recognition that HFpEF, heart failure in elderly men, may well be caused by deposition of wild type transthyretin in the heart. And this used to be a finding at post-mortem, was regarded as exceptionally rare, and improvements in imaging, particularly cardiac MRI, and the recognition that bone scintigraphy can be a very sensitive means of picking it up, has meant that we've seen an almost exponential increase in diagnosis of this disease, which has also been backed up by incredibly exciting improvements in treatment at the moment in hereditary TTR amyloidosis with gene silencing agents, but with an expectation that this may be translatable into wild type TTR as well. So again, a very happy coming together of the idea that a disease now both be much more easy to diagnose, and coming over the horizon, there may actually be effective treatments, which might mean that late onset heart failure becomes a disease which one could actively manage rather than treating with diuretics. And then the hereditary amyloidoses due to other mutations are at about 10% of what we see, and that has stayed constant. But again, the revolution in genetics, which means that we are able to extend our genetic testing and access to wide panel genetic testing has become affordable and much more easy for people to access, means that this has gone from being a diagnosis that is very, very difficult for your average, even teaching hospital physician to achieve, to being something that we will routinely do a gene panel without really thinking about it.
So Helen, thank you for this very nice introduction. My first question would be, how many of your patients will undergo a biopsy, and what are your preferred sites of biopsy to diagnose amyloidosis?
So it is still true that the vast majority of patients diagnosed with amyloid will have a biopsy, either because amyloidosis is suspected and somebody has done a biopsy looking for amyloid, or this is an unexpected finding with a protocol biopsy. So patients still are relatively lucky if they present with renal amyloid, because there is a very clear diagnostic pathway. And if you have proteinuria and a rising creatinine, you'll get a renal biopsy quite early, whereas rather more non-specific presentations of amyloid, such as weight loss or fatigue, it may take longer for a biopsy and for the diagnosis to be made. And in amyloid, early diagnosis is the key. So the majority of our patients will come with a biopsy, and it is still true that the majority of our patients will come with visceral organ biopsy, asking a question about organ dysfunction. And of the visceral organs, the kidney remains the commonest site we see. But because of the increasing interest in the heart, we're seeing more cardiac biopsies. We see a small number of liver biopsies, but they are probably genuinely slightly higher risk. Kidney biopsies, there's good literature that the risk of biopsying an amyloid is standard compared to other kidney biopsies. In AL-amyloidosis, there is now increasing literature that if you are actively looking for amyloid and doing a Congo red stain and doing it well and with adequate thickness of tissue, the combination of a bone marrow, and many of the patients with AL-amyloidosis are known to have a plasma cell dyscrasia, so they will be having a bone marrow anyway as routine care, with a screening biopsy. And the screening biopsy can be a fat aspirate, which is an easy technique to do in outpatient clinic, or a gut biopsy, gun biopsy, skin biopsy, has a greater than 80% sensitivity for picking up amyloid. So in AL amyloidosis, if you're thinking of the diagnosis, the combination of a bone marrow plus a screening biopsy is very sensitive and low risk, and also quick. In other types of amyloidosis, the sensitivity is much lower, and it may be necessary to go on to do a formal tissue biopsy. And then the truth is that your pickup rate is higher if you go for a compromised organ.
When you do bone biopsy in these patients, do you always find then an increase in plasma cells, or do you also in some cases really have normal bone biopsies and just in blood this increase in light chains?
So in AL amyloidosis, the majority of the patients we see do not have frank myeloma. They have lower grade plasma cell disorders with a lower percentage of plasma cells. And when you look at the bone marrows, there's a number of issues. So one is that they may frankly have a clone which is less malignant. And this is a spectrum from a normal bone marrow to frank myeloma. And the other one is that there is always sampling error. So it is relatively unusual for us to see patients with frank myeloma, and the majority of the patients that we see will have lower grade, either what would, if they didn't have amyloid, which is a precludes the diagnosis of monoclonal gammopathy of undetermined significance, because if you have a protein deposition disease as a result of it, it is clearly significant. But with those low levels of paraprotein and a low level plasmacytosis in the bone marrow or smoldering myeloma, I'm sorry, the semantics of how you classify plasma cell disorders and their degree of malignancy is complicated and not particularly intuitive. But the presence of a very low number of plasma cells in the bone marrow in no way excludes a diagnosis of AL amyloidosis.
Yeah, I agree. It's getting very complicated, and it's very helpful if you read these reviews about MTRS and then basically having some explanations about that. That's really amazing, I think, how the field has progressed. So you've referred to your options down in London with all this cardiac imaging. And my next question is, if you really scan all the patients with MR, or do you perform a echo as a first BART diagnosed cardiac amyloidosis?
So we are in the privileged position of having a lot of different modalities. So we can do a bit of functional testing with CPET. We can do echocardiograms, we can do cardiac MRI, we can do nuclear medicine testing. And unfortunately, as is always the case with medical testing, they don't really replace each other. They all complement each other. So these give you different facets, looking at different aspects of both cardiac anatomy and function and levels of distress. So in the ideal world, you would want to do all of them and also combine them with biomarkers, which give you different information and different dynamism. We don't do a CMR on everybody. So if patients have absolutely no suggestion of cardiac amyloid, normal performance, particularly if they have a type of amyloid where we're not particularly concerned about it and their biomarkers are normal, we would probably do an echo. And if the echo is reassuring, leave it at that. But cardiac MRI is more sensitive, both at initial diagnosis and probably in picking up serial changes, and may give better prognostic information. And it isn't moving field. So I think in the right patients, cardiac MRI is exceptionally informative, and it is probably useful in picking up very early disease, and particularly in AL amyloidosis. That's very important when it comes to long-term monitoring and making treatment choices for these patients, because in AL amyloidosis, it is cardiac amyloidosis, which is the major killer. So you wish to detect it early because it does have an impact both on how well treatment is tolerated, but also on how aggressively one would wish to treat patients.
So the next part I would like to ask you, in your experience, how do you follow up these patients? So once you have diagnosed cardiac involvement, is a BNP, for instance, sufficient, or for renal involvement, is a UACR sufficient, or do you combine it with more experimental biomarkers?
So when you think about following up patients with amyloidosis, you have to consider that amyloidosis is always a secondary phenomenon. So the damage that you're seeing in the patients is from the protein deposition, and you have to ask why they're depositing the protein. So if they have a genetic cause, they have a mutation that has destabilized their protein. And the question is, can you control the supply of the precursor from that? And we'll come on to that in a moment. There are some new treatments for particularly hereditary TTR amyloid. In some hereditary amyloid, there may be an option for liver transplantation if the majority is made of it. In the acquired amyloid, we're interested in the bone marrow if it's AL-amyloidosis, and in the clone, in AA-amyloidosis, we're interested in the levels of inflammation. In dialysis-associated amyloidosis, we're interested in the rate at which our dialysis or renal replacement therapy can clear beta-2M. So the first thing you want to do is to be absolutely certain what your fibril precursor protein is, what's happening to that, whether you're suppressing that as hard as you can, because that is the tap, which is the supply of your new amyloid. And that is the thing that is most amenable to treatment at the moment. That's about the only thing that's amenable to active treatment. So you really have to have quite a lot of your attention focused on that and making sure that you're controlling that. Then we look at organ function. And you can look at organ function by measures of organ distress, and then that's very organ specific. So as you say, proteinuria, renal function, liver function, sometimes physically measuring the size of organs. Livers and spleens can shrink quite rapidly, and it's very reassuring to watch them get smaller on the scan or physically to measure them. Cardiac biomarkers are extremely prognostically useful. These are always messy and difficult. The cardiac biomarkers are heavily influenced by renal function, also by your volume status, and in chemotherapy, they can be influenced by your chemotherapy agents. They can be falsely raised by your treatment. They're also affected by weight loss. So you have to interpret them cognizant of looking at your whole patient. And again, in kidney function, we know even in patients where you have total control of their fibril precursors, if they have pre-existing severe kidney damage, particularly if they have severe tubulointerstitial fibrosis, you may continue to lose renal function, even if you've got a complete response. And then you don't want to overtreat somebody if you know that they have 70% fibrosis and good going tubular proteinuria. It's unlikely that hammering with chemotherapy, once you've got a complete clonal response, is going to do any benefit. On the other hand, we have seen patients who have got a good 90% clonal response who have ongoing damage, where if you can push them to 100% response, you can see that their renal damage stops and may eventually reverse partially. So these are individual judgments, but you have to be watching the supply of the fibril precursor protein, what's happening to the organs, and make a judgment about what's happening to the organs. Is this progression in a terminally damaged organ that's going to progress anyway? Is this potentially reversible if you get control of the underlying disease? And also, particularly in chemotherapy, and the chemotherapy options now are complex. Many of these patients will go on to second, third, or even fourth line treatment. Are you looking at treatment-related side effects, and do you need to pull back because we are starting to risk getting cardiac or renal toxicity from the agents we use? So the decisions about initial treatment are quite difficult. The decisions, particularly for our hematology colleagues, when you come on to second, third, fourth line treatment, get increasingly complex.
So if you have a kidney biopsy, for instance, and you have congruent positivity, do you perform other phenotyping on biopsy tissues in your patients?
So when you look at a kidney biopsy, there is some information from the morphology. We don't rely on it entirely, but there are some characteristic appearances on the renal biopsy morphology which may really help you to type the amyloid. So in particular, there's a type of hereditary amyloidosis, which is reasonably common in Britain and in Northwestern Europe due to mutations in the fibrinogen A alpha chain gene. And that has a very characteristic appearance that the glomeruli are almost completely replaced by amyloid. So you see these astonishing golf balls of amyloid in a kidney that otherwise doesn't seem to contain very much amyloid. That is a pretty strong clue that you're looking at fibrinogen amyloid, with the caveat that AL-amyloidosis is the great mimic, and AL-amyloidosis can do anything and can mimic any other phenotype. AA-amyloidosis tends to be a medullary disease, so we tend to see more if somebody's done a rather deep biopsy and got a bit of medulla and you're seeing more amyloid in the medulla than you are elsewhere, that would make you think either of AA or ApoA1, but you can't rely on it. We then go on to do a full panel of immunohistochemistry, and that is one of the privileges of doing a lot of very disease-specific treatments, because these antibodies are difficult, and maintaining a big panel, you need to be doing a lot of immunohistochemistry using these antibodies all the time. They're hard to handle and keep working well. So we would do immunohistochemistry using antibodies against lambda light chains, kappa light chains, fibrinogen, LEC2, AA, lysozyme, apolipoprotein A1, transthyretin. Some of these are validated, some of these are not validated but are useful. We have more we can use, and if we don't get clear answers on immunohistochemistry, we will back it up with proteomics. Proteomics using dedicated databases which have been set up specifically for amyloid enormously increases the sensitivity and can type but doesn't type everybody.
So we all see a lot of patients with very uncharacteristic autoinflammation, I would say. But how is your diagnostic yield? How many patients with autoinflammation can you diagnose who finally move on to AA-amyloidosis, especially taking into account whole genome sequencing and the novel methods we have in hand?
Right. So autoinflammation are disorders of innate immunity causing recurrent attacks of fever and marked systemic inflammation, so very high SAA and CRP. And the characterized diseases had a uniquely high risk of AA-amyloidosis. So familial Mediterranean fever, 60% in the Turks, in some of the Sephardi Jewish populations of the North African coast, as high as 90%. The other diseases, TRAPS, TNF receptor associated periodic fever syndrome, CAPS, cryopyrin associated periodic fever syndrome, probably at least 25%. I have run a fever clinic here for 20 years, and my proud boast is that nobody known to that fever clinic has developed AA-amyloidosis. So we run an amyloid prevention clinic and say if we know about them soon enough and we manage them actively, they do not get amyloid. That was initially the prime cause for bringing them into the clinic and saying if we know about you and we manage you properly, this will not happen to you. So if you're in the privileged position of being somewhere where you can access the right drugs, which are colchicine for FMF and for the others, specific cytokine blocking drugs, so the ability to block IL-1 or IL-6, and we're coming to the point with Janus kinase inhibitors for some of the other drugs, most of these diseases are treatable, controllable, and we talk to people about expectations of pretty close to normal lives, normal quality of life, normal life expectancy. It's a hard conversation to have if you're in parts of the world where you know about these drugs, but they are not accessible, because that is a uniquely difficult situation, which quite a lot of people find themselves in. We still see people coming to us with AA-amyloidosis, and their diagnosis of an autoinflammatory disease is made after they have presented with AA-amyloidosis. In COVID, we've had 2 come. So I think the interruption of health services has meant people have come later, and they have both gone into renal replacement programs, and we're talking about getting them established and stable as possible, and then whether they can have a kidney transplant. And that is a disaster, because if we'd seen them pre-COVID, we could probably have stopped this. So I very much hope it's not going to happen. What we hope for the future with the clear-cut genome inherited autoinflammatory diseases is that we will not get them as adults, and that they will come to us through our transition clinic, having inherited them from pediatrics. And this year is the first year where I inherited as many patients as we diagnosed as adults. Before that, we've really run diagnosing 2 adults for every child who has come to us through transition. And it is worth saying that most of these patients are missed in childhood still, and we're still picking them up because the advances in genetics, even for familial Mediterranean fever, it's 25 years this year since the gene was identified. And a lot of these patients were just not picked up in childhood, and as adults, they harden to their symptoms. It's very common for us to pick up the adults when they bring their children, pretty much having learned to live with their own symptoms, but they won't see it in their kids. There are then also the very exciting new interests in somatic mosaicism, meaning that these diseases now present late in life. And so we have about 10% of CAPS, cryopyrin-associated periodic fever syndrome, that presents to us in adulthood because they are somatic mosaics and their diseases genuinely start as adults. It's not that they were missed, it's that they really do start in late adult life. And then there is VEXAS, which was only reported in 2020, and which is another, this is an autoinflammatory disease associated with myelodysplasia and is due to somatic mosaicism in UBA20. And that is genuinely a late presenting disease and is a very interesting, at least from my point of view, association of disease between myelodysplasia and autoinflammation. And there really is a very interesting field there that a dysregulated bone marrow is a pro-inflammatory state and can just drive systemic inflammation. I've sort of moved off your question. So we do see a bit, the risk is high untreated, but these are really high value diagnoses because we're in the very privileged position that we can diagnose the genetic forms, and single cytokine blockade can be incredibly effective and can mean that you can take often quite old patients well into their 7th, 8th, 9th decade and treat them with monotherapy. And although treating small children and giving them a normal quality of life is absolutely lovely, and there is no way that I want to be in the position of sounding like I'm trading a very old patient against a child, one should never undervalue how satisfying it is to take somebody in their 70s or 80s and get them steroid free and see how much better they are if you control their inflammation and can take them off all their polypharmacy and actually see somebody come back to you and say, I feel like I did 20 years ago.
Yeah, I think VEXAS is really exciting for all of us, especially how refractory some of these patients are and how difficult to manage they are. So before handing over to Marlies, I have one final question. So if you have a patient with an established diagnosis of AA-amyloidosis, how do you follow them up? Do you check the SAA level regularly?
Yeah.
And what is your target level here?
So the target is like limbo dancing. The target level is as low as you can go. So we would check at any rate to start with every month. And now a very old paper that we published in the New England Journal in 2007 showed prognosis against a time-updated analysis in patients with AA-amyloidosis against their SAAs checked every month. What that showed was that if you're in the highest octile, which was patients with really very high, significant inflammation and a median SAA of above 150, your chance of dying was about 18 times higher than patients with suppressed inflammation. But if you look at the other end of the spectrum, and you look at the 2 lowest octiles, the second lowest octile had a median SAA of about 10, and at that level, SAA and CRP are pretty much hand in hand. So that's a CRP of about 10 milligrams per deciliter, per liter, which most of us would accept as being pretty much on target. And the lowest octile had a median SAA of about 4 milligrams per liter, so a CRP of well below 5. And the difference in your chance of dying was about 4-fold. So the lower your SAA, and I hope all 4 of you and I are running median SAAs that you would see in healthy blood donors, and that is less than 1, is associated with significant improvement in long-term outcome. And so we really want to get those SAAs down as low as you possibly can. There's obviously a trade-off. If you are suppressing people and they are beginning to run into problems with infection, you may have to pull back a bit and say you're actually now starting to do more damage with your treatment and also getting more inflammation with your treatment than you would if you pulled back a bit. So there is a line to walk, but the fundamental aim of treatment in AA amyloidosis is to normalize the SAA, and a normal SAA is about 1 milligram per liter, and keep it there forever.
Well, thank you very much for this very interesting excursion through the diagnostic processes and the treatment and monitoring of AA amyloidosis. I would like to circle back a bit to AL amyloidosis, because the treatment here has been kind of revolutionized recently with the introduction of daratumumab, in addition to the standard immunotherapy for paraproteinemia. So the hematological response, the overall mortality has improved quite a bit with the introduction of daratumumab, and I feel it's already being used generously in Austria. But have you already implemented that in your routine care of AL patients? Do you face any restrictions, maybe also financially? And do you see any patients that where you're hesitant?
So we have some restrictions in that we can use it in line with patients who have a myeloma defining diagnosis. So if we cannot align them with a myeloma defining diagnosis, we struggle to use it, and we can't use it first line, we have to use it second line. I would agree, I think daratumumab has been remarkably effective and has really improved clonal responses and has been extremely well tolerated. I think our impression is that we are seeing better responses and longer maintenance of responses with relatively low levels of daratumumab in amyloid than we are in myeloma. So we're beginning to see a number of patients who've been on very long-term daratumumab, several years of treatment, and that on the whole, this has been very well tolerated. There are undoubtedly, you do run into problems with infection. Few patients have problems with allergy, as you would expect with a monoclonal antibody, and beginning to be one or two slightly worrying stories of acute renal failure. But generally speaking, this has been a remarkable introduction of a well-tolerated monoclonal antibody approach to the treatment of plasma cell dyscrasia, which has been enormously valuable. And I think the conversion of myeloma from a high-risk malignancy, where we are tended to see many patients where either you got a clonal response or things ran a fairly short course, to a much longer course disease, is going to be interesting from the point of view of amyloid, because I suspect that we are going to end up seeing a rather different pattern of amyloid, in that, having said that we see relatively little amyloid in myeloma, I think the population of patients who are in a long-term partial but not complete clonal response with myeloma, and who are living with it with a chronic disease, as a chronic disease, are at risk of amyloid. We may find that the myeloma clinics become a rich source of referral to us, as these patients who have been followed up for 5, 10, 15 years with controlled but not completely treated myeloma develop a rather indolent course and very gradually present with systemic amyloidosis. That's prediction. I don't have any evidence for that yet.
We're seeing more and more patients here as well. And so usually with paraproteinemia, the next step in younger, fitter patients is stem cell transplantation. Which patients do you consider eligible with patients with amyloidosis? Because I mean, sometimes they're more fragile. They also tend to be older, and they have severe end organ damage in many cases. And clinicians are very restrictive with stem cell transplantation.
Yeah, so I think that's right. And there is clearly, it is one of the things where practice between North America and Europe still remains quite different. So I think if you have AL amyloidosis and you have stem cell transplantation and you achieve a clonal response and you survive it and you don't lose major organ function, it was the right treatment to have. And it is associated with a better duration of clonal response than other treatments. But that's quite a long list of caveats, and it is hard to spot those patients. And as publications from the Mayo Clinic many years ago showed, I have just defined the lowest risk patient group, and that is a patient group who will do very well with almost any treatment. So yes, we consider very early stem cell transplantation for younger patients, single organ involvement, who are fit for being put through a high risk procedure. We wouldn't do it to anybody with high risk cardiac disease because the risk of dying is too high. So we would limit if they have really more than Mayo stage 2 disease, if their wall thickness is more than 15, if they have any compromise in performance status. We wouldn't do it with significant renal impairment, nor with heavy proteinuria, where they've tended to do badly. We wouldn't do it with anyone with a very large amyloid load because the risk of GI bleeding is too high. And our experience was that when they bled, it wasn't a single point bleeder you could manage. This is diffuse bleeding from a very large area of extremely fragile gut, and these patients did terribly badly. So low-risk patients, I think it's also something to consider in patients with progressive peripheral neuropathy, because the neuropathy associated with AL amyloidosis tends not to reverse, tends to rather indolent but irreversible course, and getting in early with highly effective treatment may stop a very chronic disabling treatment in these patients. The positive side is, as you've already said, the advances in treatment with the other agents has meant that the very black and white choice between stem cell transplantation, which 20 years ago was just so much better than the other options, has become much less clear, because if you start combining proteasome inhibitors, the next generation of agents derived from thalidomide, monoclonal antibodies, these combination therapies, which are ferociously expensive, which is a problem for healthcare providers around the world, their efficacy is extremely high. So if cost is no issue, in terms of frank efficacy, certainly for the first year or two, there is a pretty close match. I think what we endlessly discuss is timing of stem cell transplantation. So if you have somebody who is on the edge, do you want to treat them, get them into response with something that feels a bit lower risk, monitor, as Andreas has already said, your key organ function, and see whether you get yourself a window where they're in a clonal response, their proteinuria has dropped, their performance status is better, and then think about transplantation then, when you may have a lower risk patient. And these are very individual choices to be made by the physicians in combination with the patients.
And so all of these traditional treatments and also daratumumab, they aim towards a reduction or even elimination of the precursor protein. But there have also been some studies that rather aimed at a removal of the amyloid deposits, such as small molecule treatment or antifibril monoclonal antibody studies, some of which were terminated early. But there recently has also been one study that was published in Blood on an antifibril medication, and that was only a phase 1b study, but it showed very promising results. What do you think of that? And do you also maybe see potential for AA treatment with similar agents or the same agents even?
So the holy grail of treatment of amyloid is, what we would all want is a treatment that cleared the amyloid fibrils, because that is the pathology. That is why organs are failing. That is why the patients are sick. If you could do that, get your patients as well as possible, and then you definitively treat the underlying condition. So no chemotherapy until you've got them as close to normal as possible, and then you put them through stem cell transplantation, even unrelated or related bone marrow transplantation, actually try and get a clonal cure. That is our science fiction. That's what we all want. The question is, are we going to have agents that effectively clear the fibrils and clear it in real time? And the physical direct disruptors, the idea that you can put something into the fibrils and disrupt them enough that they are cleared, either because they're cleared by circulating macrophages or that they're just physically disrupted enough that they start to fall apart. I think it's got some problems, one of which is that there's really quite a lot of amyloid in most patients, and you'd have to get an awful lot of drug in order to physically disrupt enough amyloid. So I think that's a lovely idea, and I can sort of see it working in a mouse, but in a 70-kilogram human, I just kind of wonder about how much drug you're going to deliver, particularly if you look at somebody with a fairly substantial amyloid load. But it's a nice thought, and particularly perhaps for the hereditary amyloids, where you're looking at relatively small amounts of amyloid in highly damaging locations such as nerves, there may be more of a place. For the antibody-mediated therapy, it's clearly very, very attractive. There is a line to walk. If you are getting enough antibody-mediated clearance, that it's helpful. That needs to be without causing local inflammation in organs that are already significantly compromised. So you are asking to have antibody-mediated clearance that is not causing any local inflammation or any dip in function, and that is not going to be associated with fibrosis as the deposits are cleared. It's not impossible, and I agree some of these studies look really promising, and that would be a great outcome. Whether there is going to be an antibody that is specific for all antibody type, for all amyloid types, so whether there is an antibody that is going to recognize a common component of all amyloid fibrils, so one of the constituents that binds to the protein, such as amyloid P, serum amyloid P, or glycosaminoglycans or apolipoproteins, or whether it's going to be fibril specific and therefore specific to an amyloid type, I think time will tell. AA is an interesting question. I mean, one of the risks with using antibody clearance is that you may get an inflammatory response. And if that is associated with a rise in the hepatic acute phase response and a rise in SAA and CRP, you may get a rise in amyloid production at the same time that you're clearing. And if you're designing trials, that may get quite difficult to read if you're depositing new amyloid at the same time that you're clearing old amyloid. And I think you would have to think very carefully about how you could measure outcomes if that was a risk. So it's interesting, and I think as with many of these things, the devils are in the detail, but there's a lot of interest in it from a lot of different drug companies, and there is, as you say, a lot of encouraging preliminary results. And the cure for amyloid is going to be removing the existing fibril deposits. I think turning off the supply of the fibril precursors, which is where we are at the moment, is great, but it's always going to be a slow burn treatment. And for patients who come late, we will still be looking at our early mortality, which in AL-amyloidosis is between 25 and 30% of the patients who are too advanced for us to turn around. And dropping that early mortality is going to need a completely new approach of targeting their existing amyloid.
Thank you. I really appreciate this honest answer. I would also like to ask one or two more questions on transthyretin amyloidosis, if that's okay. Maybe a very naive question. Previously, you mentioned that it's a rather male disease. Men are affected more often than women, but at the same time, women live longer than men. So why are men affected more frequently by this disease of old age?
It's a really good question, and I don't know. Men are more affected by amyloid in the general. I mean, you know, they're the frailer species, they're the frailer half. They're more affected by everything in general except pregnancy. But men in general are more vulnerable, including AA-amyloidosis. Even when you look, when rheumatoid arthritis was the major cause, there is still too much amyloid in men compared to women. So there is a gender predisposition in general, but it's much, much more striking in wild-type TTR amyloid. We don't see it in hereditary TTR amyloid where the sex distribution is equal. So whether this is related to testosterone, whether it's related to muscle bulk, whether it's related to stresses through the heart, there's this very interesting observation that we see a disproportionate number of patients who have been physically very fit. So it's not everybody, but wild type TTR amyloidosis, the characteristic history of people who have been physically fit, either have done physically active jobs, farmers, builders, or people who have lifelong performed at a high level at sport. And you almost, it's really characteristic as you sit in clinic that people will have been cyclists, will have been runners, will have been bodybuilders, will have been really good recreational sportsmen, occasionally will have been professional sportsmen. So there may be something physical about actually how hard blood is pumping around your heart and disrupting the TTR molecule, and that women are just not traumatizing their proteins quite as badly. But it's a really good question. There are all sorts of terribly good questions about TTR amyloid. Why does bone scintigraphy pick it up? Is an unanswered question. The distribution affecting soft tissues, that we have carpal tunnel syndrome, which often predates the cardiac disease by more than 20 years, the tendency to rupture tendons, the involvement of the ligamentum flavum, with frequently a history of spinal stenosis. As with all types of amyloid, the organ trophism is not explained. So there's an enormous amount of clinical research to keep going, and lots of interesting questions.
In patients with hereditary transthyretin amyloidosis, do you offer genetic counseling very early on, and do you push patients towards combined liver and heart transplantation?
So I think it's a brilliant question. This is changing and is very difficult. So hereditary TTR amyloidosis, before the recent advents in treatment, was a family devastating disease. This is an autosomal dominant disease. Family members will have watched their older relatives die in the most distressing fashion over 10 to 15 years of a progressive disease associated with largely peripheral and autonomic neuropathy, with muscle wasting, loss of mobility, becoming wheelchair bound, loss of sphincter control, just an appalling loss of autonomy, loss of control of your body, dreadful way to watch your loved ones die, and a terrible level of fear that it will happen to you. And early diagnosis has carried risks to people. I'm not sure that one wished to diagnose that in people in their very early 20s, particularly in a family where it was late onset, because you could really, really destabilize somebody and damage their emotional and mental health. And when there weren't treatments, it wasn't clear. With the advent of treatments, and now licensed treatments that are available, that has changed, because you now do want to pick people up in order to be able to put them on treatment when they develop disease. But the treatments are not being used preventatively, and these diseases all show both variable expressivity, meaning that when you develop disease, varies a bit in terms of your age at presentation, also the way in which you present, and also variable penetrance. This is not Huntington's disease. Carrying the gene does not give you a 100% chance of developing disease. So if you're talking to somebody about genetic testing, you need to talk about the risk of having a positive gene or a negative test. If you have a negative test, you don't have the disease and you cannot pass it on to your children. If you have a positive test, there's a possibility both of you having the disease and of you passing it on to your children. But also that if you have a positive test, it's not possible at the moment to reliably tell people their absolute chance of becoming ill in the future, when it will happen. And as is often the case with these diseases, the early symptoms of the disease are things that we all recognize. Bit of peripheral tingling, change in your bowel habit, feeling tired. Symptoms that all of us get on a day-to-day, week-to-week basis. And you have to give people the tools to recognize what is pathologic and a red flag, and what is you went to sleep with your arm in an uncomfortable position and you've got a tingly hand. Because you can destroy somebody's confidence in their health and in their ability to settle down, complete their education, have a job, settle down, start a family. And so I think they do need very careful genetic counselling, and then they need an agreed follow-up. And again, there's a line to walk, which I don't think there's a right answer to, about what is the appropriate level of screening that you're not missing things, and what is the level of screening in which people never feel safe because you've been told everything's all right on your current test, but you're now in an absolute panic about the tests which are going to be repeated next year, next month. And what if they're not normal? And how do people manage their life with a disease which may not manifest for 20 years? So yes, we do, but these all have to be discussed, and it's easier if you know from a family when they develop their disease, if it's consistent, and if you talk to people about when you're going to start screening, and preferably only a few years before you're expecting them to start developing early symptoms.
Thank you. So that really shows that amyloidosis is just a whole set of different diseases, actually.
Yes, and
In your clinic. Thank you very much.
So apparently men are also more often affected by logorrhea. That's why I would have one additional question on this association between exercise and deposition disease, of which I never heard before. So do you have some kind of gut feeling? How much exercise does it need to be really at risk? Is this somebody who does an Ironman before breakfast in the morning, or like Andreas climbing each weekend on high mountains, or also the ordinary, well, leisure time sportsman who does jogging tours each other day or something like that?
I think one has to start by saying this is a disease of the old, and you are, of course, more likely to survive if you are physically active. And so this is in no way a suggestion that people shouldn't be physically active. And it is not clear, of course, whether we still don't know whether it is being physically active that gives you disease, or whether your genetic background that means that you are capable of being high performing physical activity, that in part puts you at risk of it. So association is not causation. And if you look at the over 80s who are more at risk of getting a TTR amyloidosis, you know, they also led healthier lives and didn't smoke. And I'm not suggesting for a second that not smoking is also a reason for developing TTR amyloid. So we don't know is the answer. And I don't think I can answer that except for saying it's an interesting association, but in no way would I suggest for a second that people shouldn't do the level of exercise they're happy with.
But it's fascinating anyway, because even exercise doesn't seem to be a black and white issue. So we heard some years ago that there's an association between exercise and atrial fibrillation. Now, apparently there may be something else. Surely the benefits are much stronger than the risks, but apparently it looks as if everything we do has a certain kind of risk. So interesting to hear anyway. So
everything in moderation.
Yeah. So thanks a lot, Helen. This was a fascinating tour across all types of amyloidosis. Thanks for being our guest, and surely thanks for doing all these studies and for caring for all these patients. Thanks so much, and have a nice evening in London.
Thank you very much for inviting me.